My name is Terry Mulligan. I'm a professor in emergency medicine at the University of Maryland School of Medicine in Baltimore, Maryland, in the USA. Well, emergency medicine used to have a very high burnout rate. So historically, emergency medicine is a pretty young specialty. In the US and the UK, it's about 50, 51, 52 years old, which is young for medical specialties. And in other places in the world, it's often younger than that. And so this concept of emergency departments, emergency care systems, those are still kind of in the early stages of development in most of the world. And it used to be that before we developed specialized training and special systems in the emergency departments, that burnout was very high. And typically that was because the people who were working in that setting were not trained to work in that setting. They may have been trained in a different area of medicine, like surgery or internal medicine or anesthesia, or maybe they were trained as a GP. Of course, in some places in the world, some of the people working are not even fully trained doctors. So it makes sense that if you're working in a very crazy, hectic, complex environment where there are very, very sick people, that if you're not trained to work in that place, it can be very stressful and cause these symptoms of burnout. So what happened over time was the doctors who were working in these settings realized in order to work here, you really need to be trained in order to work there. The doctors who had that training in surgery or anesthesia, they realized that training was good for those types of patients, but maybe not for the other types of patients. And so over time, the world has kind of come up with emergency medicine, which is this special training. So what happened is burnout used to be very high. And then when training started coming in, training of the doctors and nurses, the establishment of what an emergency department does, and having a good development of the emergency system, what we saw was burnout amongst emergency doctors, which used to be very high, started to go down and down. And that makes sense. If you train people how to work in a very complex setting, then their stress level goes down. There's a lot of different ways. There are scientific ways, there are ways of using psychological and statistical methods. There are a lot of different studies that have looked at this, at burnout rates. But really what burnout is it's a combination of psychological, physical, behavioral symptoms that a person feels, and it's because of what has happened to them in the place that they're working. But I think there's a lot of talk about burnout among doctors, which is on the rise in most systems. And emergency doctors tend to have very high burnout rates, either because they don't have good training, or, like in the case of US, the burnout rates went down and now they're going back up again. And I think it's because the system is overutilizing, over-relying on the emergency department. And we call this, this symptom burnout, but I think it's an error, it's a mistake to call it burnout. What we call something, the words we use to name something, change and affect how we think about it. And so calling it burnout tends to put the blame on the victim. If you're a physician who's burning out, calling it burnout tends to say, well, this is your problem, this is your fault. These are things that are happening to you, and the solutions that a lot of the burnout literature talk about are really solutions are suggestions that you need to do for yourself. You need to take more time with your family, you need to take more time to sleep and exercise, you need to have more mindfulness, you need to have mind-body awareness, you have to do more yoga. But we're not suffering from yoga-penia. We're not suffering from a lack of deep breathing. What we're suffering from is abuse. Burnout is abuse. The system is abusing us. Back in, there's a comedian who has a story about this. Back in World War I, there were soldiers working in the, living and fighting in the trenches and in the war zones who were exposed to the bombs and war, and were having their nervous system snap or nearly snap. And they called that shell shock. So 2 words, shell shock, and it's very descriptive of what it is. It's But by World War II, with the same situation, different soldiers but the same situation, they stopped calling it shell shock and they called it battle fatigue. And then in the Korean War in the USA, they didn't call it battle fatigue anymore, they called it operational dysfunction. And then after Vietnam, they call it post-traumatic stress disorder. And so now it's 8 syllables with hyphens in it. It's completely removed from shell shock. And he makes the joke, I bet you if we called post-traumatic stress disorder, if we still called it shell shock, we probably would be treating those soldiers better. They probably would be getting the care that they need. And so I think by calling it burnout, we're blaming the victim. Just like PTSD has a tendency to blame the soldier, There's a doctor in New York City named Louis Goldfrank, one of the fathers of emergency medicine for Bellevue and NYU Hospital. He says, every patient who presents to the emergency department represents a failure of the public health system, which means if we had a perfect functioning public health system, people wouldn't come to the ER. We would have prevented those car accidents or heart attacks. We would have prevented those drug overdoses of the depression or the suicide attempts or the chest pain, et cetera. Now that's going to be a long time before we have that system in place. But emergency medicine really was pulled into the existence. It exists because of all the holes in the healthcare system. And so because of that, we see everything. We see men and women, young people, old people. We know a little bit about all the emergencies. And the system relies on us to take care of all of the holes in the system. And as an emergency doctor, I don't mind that. I like it. But I have to be able to do it. I can't take care of it with one hand tied behind my back or 2 hands tied behind. So what the system has done, I think, in the last 20 years is it uses us too much. And we're becoming burned out. We're like those soldiers it's not as bad as the trenches, but it's bad. We're working in an environment, a crazy, wicked, perfect storm environment that produces burnout. Burnout is the proper, correct physiologic response of human beings who work in that environment. And so we should expect it to happen when we put people in there and make them see more and more patients, see more and more, do more and more. When things go wrong, we blame them. And so we shouldn't call it burnout anymore. We need to call it what it is. Burnout is abuse. The system is abusing us. Well, I think the first step, the way forward, is to look at it properly, to figure out what is the real cause of this. Now, some of us are workaholics, or we love work too much and we love it. Maybe we're working, we're not exercising anymore. And that we do have some personal responsibility in this. But I think overwhelmingly, once we realize that this is a crazy environment, when we're asking doctors to go take care of 4, 5, 6, 7 patients an hour, complex, sick people, in the average ER, 1 out of 3 people is sick enough to be admitted. These are sick people. And so a lot of times they get admitted and they don't get it brought to the ward or to the ICU because there are no beds. And so now we have to take care of them and the next people and the new people. And we're trained to do it, but there's only so much you can do. I can see 20 or 30 patients. I can't see 100 patients. And so one of the things is, let's call it what it is. It's not a problem with us. It's a problem with the system that is over-relying on us. And so if you were running on a car odometer at 4,000 RPMs, we can handle it. But if we're running at 9,000 RPMs all the time, you can do that for a little while, but eventually your nervous system is gonna crack. And I think that's what's happening to the emergency system is a lot of things, but the healthcare system tends to use it as an extra overflow catchment area, like a Band-Aid. It uses it to fix the holes in the system. And it's so effective that it's using it more, and 5 years later it's using it more, and we're doing more, and the ERs are getting fuller and fuller, sicker and sicker. We're doing more and more. So I think we have to understand why the burnout is happening, because the system is abusing us. Sometimes intentionally, sometimes not intentionally, but it is abusing us. That's number one. I think number two is, well, now we know how to address those things. I think the ER, the emergency department, is actually what we found out in the last 20 or 30 years. It's really the economic engine of the hospital. It's the patient safety engine of the hospital. It's the admissions engine. It's the diagnostic engine, the early recognition engine. And when people come in, we take care of them and treat them, recognize them, stabilize them, treat them, diagnose them often. And people come in the front door of the ER. They go out the back door of the ER, but we've given them this value. We've kind of sprinkled, like those color runs where they throw the powder on you. We've sprinkled value on them by diagnosing them early. We diagnose them today instead of tomorrow, and we admit them now instead of next week. We make 12th grade mistakes instead of first grade mistakes. And people go out the back door with this huge added value. And the hospital benefits, the patients benefit, the healthcare system benefits from that value. But what happens is, I think they go out the back door and they go through this spaghetti strainer into 300 different streams, and they go to the ward or the ICU or the clinic, and who gets the credit for all the value? They get the credit. They get the income. They get the Christmas cards. They get the thank you letters, which is fine, but what we need to do, I think, is gather all that back up, measure what that value is. What is the real value that we offer to the healthcare system? And when we measure that, we can then, that's where the resources come from to improve this wicked situation.